feature of nephrotic syndrome, suggesting prednisolone in a maximum dose of 80 to 120, and high doses as a pulse steroid may be considered, and you must treat for 16 weeks. And the steroid must be slowly, I press slowly for FSGS 6 months. You can suggest CNI as a first line of treatment. Actually, that's what I am doing, if there is a relative contraindication. And if there is a relapse, consider relapse as minimal change. And if you're steroid resistant, consider cyclosporin. And if there is a partial remission, consider cyclosporin or for a slow tapering. And you must do in FGS slow tapering. But look to the evidence. It is 2D. If you can recall all the slides, the evidence is 2D, which is the least. You can do whatever with all the development we have in idiopathic GN. This is idiopathic membranous nephropathy, and you can see the double contour in the silver in the head, and then, of course, the deposits, either subepithelial deposit. Evaluation, you must evaluate to exclude other causes of membranous, of course, that's the main issue. And the recommendation, you must not treat except a nephrotic syndrome. I can recall a debate by Hutchison and other professors a long time ago when to start a treatment for membranous nephropathy idiopathic. And actually they said 4 grams. The debate was 5 grams. I don't know from where they get the 4 grams, maybe because of the study. The evidence is a little bit good, which is 1B. So less than 4 grams, you cannot treat by immunosuppression the idiopathic membranous. And that's actually our policy. If you severe or a disabling nephrotic syndrome, or serum creatinine rising by 30%, or the GFR is decreased, don't give immunosuppression. Do not use immunosuppression in patients with serum creatinine persistent more than 3.5, because this will not help your idiopathic membranous nephropathy. And alternate monthly cycles of 6 courses of either oral IV corticosteroid and oral alkylating agent. And cyclophosphamide is coming first with the steroid. And we recommend patients to manage conservatively for 6 months following the completion of this regimen. Actually, this is important as it is related to my latest slide, because we have a spontaneous remission up to 50% in these patients. You can repeat the kidney biopsy if something going odd, creatinine going up, and you can adjust the dose of cyclophosphamide or chlorambucil, and continuous daily, not cyclic, they suggest, but although this is a debatable. The coming CNI coming late in idiopathic membranous. So idiopathic membranous, it is a steroid plus cyclophosphamide mainly. And they suggest CNI to be continued for 4 to 8 weeks. And regimen not recommended, you don't recommend to give steroid alone in idiopathic membranous. And actually this is with the lupus also. You cannot treat with, and you cannot give monotherapy with MMF in idiopathic membranous. The MMF, although the propaganda is going late, and suggests if relapse of nephrotic syndrome, reinstitution of the same treatment. And the prophylactic anticoagulation is recommended if you have additional risk of thrombosis or there is decreased albumin. This is the mesangial proliferative glomerulonephritis, and you must evaluate for other causes because this is the common, you cannot find idiopathic, very rare. Here, the only here is MMF coming earlier with the cyclophosphamide with membranous-proliferative. But look to the evidence, it is 2D. You can do whatever you like. And going through, there is infection, which I will not go through because of the time, but mention one thing about schistosomal. This is a schistosomal biopsy with schistosomal Mansoura in our region, and they recommend an antiparasitic agent in a sufficient dosage. But actually, a lot of debate about the benefit of giving antiparasite in a well-established schistosomal Mansoura nephropathy. They suggest that corticosteroid immunosuppressant not to be used, and this is 2D, and actually this may be against the practice of most of us. So you must do a blood culture to exclude typhoid, and if so, you must give anti-salmonella. Of course, immunoglobulin and other things I will just for the completion, I will just mention the names. Treatment of anti-GPM. Mr. Chairman, allow me to finish by take-home message. Immunosuppression protocols can cure some of the GN, but may be rubbish to use in others. However, most importantly, they can kill quite a few of your patients. Spontaneous remission, partial or complete, do occur in some GN, hence must look for, anticipated, managed accordingly. And my last statement, Mr. Chairman, in absolute term, guidelines must be respected, are helpful. Sometimes, actually, but not always, must be followed. However, to my dear doctors, a young physician, the golden rule is you are the one who may be blamed or get the credit, as you are the physician in charge and responsible of your patient, not the one who wrote the guideline. Thank you very much.
Thank you, Dr. Ahmed, about this nice and informative talk. And next speaker, invite Dr. Mohammed.
You just feedback at the end?
Yes. Nasrallah. We invite Dr. Mohammed Nasrallah to talk about short and long-term effect of alkali therapy in chronic kidney disease. Dr. Mohammed Nasrallah.
Bismillah ar-Rahman ar-Rahim, alhamdulillah, wa salatu wassalamu ala rasulillah. Today we'll be speaking about alkali therapy in patients with CKD. What we will be doing is we'll be talking about patients with CKD. We will start by a short reminder of the acid-base homeostasis, and we'll explore the rationale for alkali therapy, experimental, observational, interventional. But what we won't be doing is we won't be talking about alkali therapy in acute settings, and we won't be talking about detailed acid-base physiology or acid-base disorders. As a reminder, we know that we produce about 1 milli equivalent of hydrogen ion per kilogram per day. This comes from catabolism of proteins and protein metabolism. It also comes from anaerobic oxidation of carbohydrates and fats, as well as from bicarbonate losses in the GIT. The net result is that we have a pH of 7.4, a bicarbonate concentration in serum of about 24 milliequivalents per liter, and a hydrogen concentration of 40 nanoequivalents per liter. Of course, 40 nanoequivalents per liter is a very, very, very small concentration compared to the amount produced, because I'd wish to remind you that 1 milliequivalent contains 1 million nanoequivalents. The buffers for this huge acid production are bicarbonate in serum, as well as proteins, intracellular proteins like hemoglobin, for example, but also in chronic settings, in settings of chronic low-grade acidosis, bone becomes also a very important buffer for the acidosis. The role of the kidney in keeping the acid-base homeostasis is first by reclamation of the bicarbonate that is lost in the by filtration. We bring back the bicarbonate. We also secrete hydrogen ion through the proton pumps in the distal tubules. We excrete acid buffers like phosphates and sulfates. And very importantly, we also produce ammonia, which traps hydrogen ion in the form of ammonium inside the tubules. In patients with chronic kidney disease, we should expect that many of these functions are affected with nephron loss. Ammoniogenesis is increased per nephron, but the total is generally decreased because of loss of nephrons. And what you get eventually is patients with less serum bicarbonate, more acidosis as CKD progresses from stage 1, 2, 3, 4, and to 5. Now, this acidosis has so many pathophysiological implications, and this is how we're going to start trying to rationalize if we should treat this acidosis or not. Pathophysiologically, this acidosis will result in lots of endocrine disturbances. One of the most profoundly affected endocrine glands is the suprarenal glands. ACTH is increased, glucocorticoids are increased, mineralocorticoids are increased with acidosis independent of any renal failure, and catecholamine resistance results. Of course, catecholamine resistance could mean that hypotension will ensue, and increased glucocorticoids and mineralocorticoids could at least partially explain why we have increased protein catabolism with acidosis. Mineralocorticoid excess could also be a concern when we start talking about adverse cardiovascular outcomes and progression of kidney disease. So we also get growth hormone resistance. There's a reduction in the number of IGF receptors, hyperparathyroidism, insulin resistance, and lots of thyroid disturbances, reduction in free T3 and free T4, and increase in the levels of the reverse T3. Of course, all of these endocrine disturbances would be expected to affect our metabolism. Protein metabolism is profoundly affected by acidosis. We have lots of experimental and biochemical evidence on that. We know that there are several pathways, including the ATP-dependent ubiquitin proteasome pathway, which could be activated by insulin resistance. This results in protein catabolism. Also, branched-chain keto acid dehydrogenase is affected by steroids, and this causes more protein catabolism. There's also decreased protein synthesis. There's evidence from tissue cultures where cells are put in acid medium. Protein synthesis is reduced. Giving rats and dogs acids makes them produce less proteins, and even giving humans ammonium chloride in experimental settings will result in lower production of amino acids and proteins. So we have increased catabolism that is documented experimentally because of the acidosis. Bone metabolism is also affected. In chronic acidosis, bone becomes an important buffer for the acid, for the excess acid, through ion exchange. Hydrogen ion goes into bone and is in exchange for sodium and potassium. When hydrogen ion goes into bone, it reacts with the carbonate, and this could result in dissolution of the bone matrix. There's also increased osteoclast activity and decreased osteoblast activity, and the net result that we would expect is osteopenia and loss of bone with chronic acidosis. Inflammation, acidosis per se, independent of any other uremic risk factors, can result in lots of inflammation. There is evidence, also experimental evidence, by incubating macrophages in acid medium can result in an increased production of tumor necrosis factor alpha, for example. So we have lots of experimental evidence and lots of biochemical rationale to tell us that acidosis can be harmful. But is this good enough to make us start treating acidosis with bicarbonate or whatever way? Actually, as we all know, it is not enough to rely on biochemical evidence to treat a disease. We need more clinical data. We have some data from observational studies. We know that patients with acidosis complain from malaise, as we said, osteopenia. They're more liable to be hypertensive, hypertriglyceridemic, and they have a reduced respiratory reserve. But actually, the reverse epidemiology in patients with chronic kidney disease has shown in observational studies totally unexpected effects. The association of acidosis with, in patients with chronic kidney disease, acidosis is actually associated with better survival. It's associated with better BMI, better dry weight in patients on dialysis, and in many circumstances even better. Lots of nutritional parameters are improved in patients with acidosis. And this can be explained actually by the reverse epidemiology factor. We know in patients with chronic kidney disease that they tend to do better when they have higher blood pressure, they tend to do better when they have a higher BMI, and they tend to do better when they have higher cholesterol, which is in contradiction to the general population. And we know that this could be because those patients have a better appetite. Patients with a better appetite will eat more protein, and when they eat more protein, they tend to be acidotic. So actually, it could be the other way around. It's not that the acidosis is making those patients better, but it's because those patients are better, they're eating more protein, and they have more acidosis. So observational studies can be confusing. And here, this is the usual J curve or the U curve that we see in biology all the time. We see it with uric acid, we see it with blood pressure, we see it with parathyroid hormone, with calcium. Almost any parameter that you can think of in the biological system will have a U-shaped curve. So if a patient has severe acidosis, this makes the patient more prone to mortality. And if the patient is towards the alkalotic side, this also puts the patient at higher risk for mortality. And this can be, again, explained by the reversed epidemiology phenomena within limits. So again, is this enough? Observational studies have actually confused us. We need interventional studies. Interventional studies have unfortunately been equivocal in so many circumstances. Perhaps only with potassium, patients receiving bicarbonate and improving their acidosis with bicarbonate therapy have lower potassium. Nutritional parameters have been very contradictory. The results have been very contradictory. In some circumstances, correction of acidosis has resulted in improvement of nutritional parameters, but in many other circumstances, this was not validated. There was no improvement in blood pressure, in bone parameters, or even in hospitalizations and mortality in many circumstances in interventional studies where patients were treated for their acidosis. So it seems that treatment, up till now, treatment of acidosis in patients with chronic kidney disease may not really be paying off that well, at least from the studies that we have so far. But the pendulum now is going to move in the opposite direction. I'm just going to be telling you exactly the opposite of that. I'm going to try to convince you now that it could be useful through other interventional studies on progression of chronic kidney disease. So let's start it all over, but this time we'll be talking about progression of chronic kidney disease. We'll go from the beginning again, rationale, with pathophysiology. Patients with chronic kidney disease have acidosis, and we've talked about that. Acidosis means that you will have higher ammonia production per nephron, and this can activate the alternative pathway of complement, which can induce or facilitate interstitial fibrosis. Acidosis will also stimulate the renin-angiotensin system, and we all know how that could be harmful to the kidney, and also will increase endothelin. Now, endothelin can be very useful because it will promote hydrogen acid secretion, but through its endothelin A receptors can also be very harmful and promote fibrosis. So this is how acidosis can be very harmful and result in more interstitial fibrosis and kidney disease. Again, we have experimental evidence that bicarbonate therapy can be useful. Giving bicarbonate to rat models with chronic kidney disease can result in less tubulointerstitial fibrosis, can result in less progression of cyst or enlargement of cyst size in patients with polycystic kidney disease. It does result in a reduction in the ammonia genesis and a reduction in the endothelin in urine.